Klumpke'S palsy. Traction or tear of the lower trunk of brachial plexus. Partly C8 and mainly T1 roots are involved. The brachial plexus is a complex network of nerves that originates in the neck and shoulder region formed by the ventral rummy of the lower four cervical nerves C5 to C8 and the first thoracic nerve T1, which supplies motor and sensory innervation to the entire upper limb. In the diagram it is clearly visible that there are three trunks of the brachial plexus and the lower trunk gives origin to ulnar and medial nerve. Causes. In infants due to upward force on arm during delivery. In adults due to trauma, for example grabbing a tree branch to break a fall. Excessive abduction of arm. Cervical rib. Cervical ribs are extra ribs that arise from the seventh cervical vertebra and can create a constricted space in the thoracic outlet where the brachial plexus passes. This compression can lead to nerve damage. Malignant metastases from the lungs in the deep cervical lymph nodes. When cancerous lymph nodes enlarge, they can compress the nearby nerve fibers leading to nerve damage. Muscle deficit. Intrinsic hand muscles. As ulnar, C8, T1, nerve supplies the intrinsic hand muscles. Lumbricals, as ulnar and median nerve supply them. Palmar interossae. As ulnar nerve supplies them. Thenar muscles. As median nerve supplies them. Hypothenar muscles, as ulnar nerve supplies them. Effects. Total claw hand. Hyperextension of the metacarpophalangeal and flexion of the interphalangeal joints. The extensor digitorum is unopposed by the lumbricals and interossae and extends the metacarpophalangeal joints. The flexor digitorum superficialis and profundus are unopposed by the lumbricals and interossae and flex the middle and terminal phalanges, respectively. Cutaneous anesthesia along the ulnar border of forearm and hand, as the ulnar nerve supplies sensory innervation to the skin on the ulnar side of the forearm and hand. Horner syndrome. Ptosis drooping upper eyelid. Myiasis constricted pupil size. Anhidrosis absence of sweating. Enophthalmos sunken eyeball appearance. Loss of ciliospinal reflex, which is pupil dilation reflex. Horner syndrome is due to injury to the sympathetic fibers to the head and neck that leave the spinal cord through T1. Skin areas with sensory losses warmer due to arteriolar dilation and drier due to absence of sweating. Dry scaly skin due to long-standing cases of paralysis. Nails crack easily and pulp of the fingers atrophy due to impaired blood supply and loss of innervation. Mbbs versus Klumpke'S palsy. Klumpke'S palsy mainly T1 and partly C8 affected. Cause due to undue abduction, fall on the shoulder. Intrinsic muscles of hand lumbricals interossae hypothenar. Thenar muscles paralyzed. Sensory loss on medial side of forearm. Complete claw hand. Horner syndrome may be there. Site of injury. Jury is the lower trunk of brachial plexus. Mbbs palsy mainly C5 partly C6 involved. Cause due to birth injury, fall on the shoulder. Mainly biceps brachii, deltoid, brachialis, brachioradialis paralyzed. Sensory losses on the lateral side of forearm. Waiter's tip position. No Horner syndrome. Site of injury, upper trunk of brachial plexus. A 28-year-old woman presents with a classic clinical scenario of Klumpke'S palsy characterized by a fall onto an outstretched hand resulting in a brachial plexus injury. She complains of severe pain in her shoulder and arm with numbness and tingling in her hand and fingers. Examination reveals weakness in her intrinsic muscles of the hand, particularly the thenar and hypothenar muscles, resulting in a claw hand deformity. She also exhibits Horner's syndrome with ptosis, miosis and anhidrosis on the same side, indicating a lesion of the T1 nerve root. The patient has difficulty grasping and manipulating objects, and her hand is in a flexed and adducted position consistent with Klumpke'S palsy. The key points have been highlighted. Fake it because you know one day you will make it. Subscribe, like, share, comment.